Excellent. Well, welcome everybody. Uh, Thank you for joining us today. As I told some of the guys on the line, we are working on getting an amenable resolution to meeting back at the JCC. But with the uptick in COVID cases right now, especially indoors and especially at the JCC, this is probably not a bad thing to be online this month. We'll see what's happening by next month, but we'll keep the meetings going. It's just a matter of, for practicality, for time and for safety, where they're going to be. But today, we are honored to have one of our own members. Dr. Ed Melman is going to be speaking with us. David's going to say a couple of words, and then we'll let Ed introduce himself. We'll have this recorded for everybody who can't be on.
Good morning.
Thank you. Good morning, Ed. Good morning, everyone. I want to thank Ed personally because he has stepped in to fill a void. We had a different speaker set up for this month, and they had to back out for reasons where he wants to be in a live meeting, not in a Zoom meeting. Ed and I have talked about Ed being on a couple of times over the last few years, so thank you very much for joining us. I think he's had a very busy schedule. He may be going on some kind of a vacation, just had a wedding of some sort that he attended. So Ed, thank you very much. If you'll start with a short bio, we welcome you. Thank you.
Let me start out by saying that it has been a very busy week. I was very happy to have my niece get married on Friday. So we had a very enjoyable night out. I'll be leaving for Israel on Wednesday to pick up my daughter, who's had a year at a seminary in Jerusalem, and I'll also be seeing my son, who's made Aliyah and now has 3 kids and is living in Bet Shemesh. So we've been getting ready to pack tomorrow. In terms of a brief bio, I have a private practice in Voorhees, New Jersey. I've been a longtime president of the local society, the West Jersey Optometric Society. Rich Moskowitz sometimes joins us there. And we have an interesting practice. I've seen basically patients from birth to death almost, and we have some interesting technologies which I'll go into a little bit later. But one of my missions is to help to promote eye health in the area, and I'll be happy to answer any questions that are related. The topic for today is going to be eye health in seniors, so I'm going to try and share my screen. Anyway, I wanted to thank everybody for coming to the meeting today. Unfortunately, we're not able to have bagels, but hopefully I'll be able to give you some food for thought. Now, today there are 4 main problems that we see that are primarily affecting the older population, and we're going to go over that. These are age-related macular degeneration, cataracts, glaucoma, and diabetic retinopathy. That's far from the only things that we see, but they're probably the most common and ones that probably almost everybody has had somebody in their families affected by. Are you able to hear me okay?
Yes.
Yes.
Okay. This is a view of what people looking at the pasture land should see. Everything should be sharp and clear, and the skies are not cloudy all day. However, if you have macular degeneration, it's like having a fingerprint in the middle of your field of vision. You have a smudge, and that's something that over time can gradually enlarge. It never will affect your total vision. Macular degeneration will not cause you to have loss of side vision. So people with macular degeneration are able to walk around without bumping into things. They're able to function. But the number one complaint that they have for me is that they can't read anymore. And that's something that is a tremendous frustration. Watching TV becomes difficult because you look around, you can find a place where it's best, but everything is garbled. There are two basic types, wet and dry. And the wet one is one that will advance most rapidly, and that's the one that we can treat if we catch it early enough. So it's vital that if you ever start noticing that things are distorted, that your vision starts to change, that we know about it as soon as possible. Because if we can get it at the early stages, we can keep it from advancing. And the way that that's done is by the use of something called a vascular endothelial growth factor inhibitor. You don't have to remember all the words, but the bottom line is that this is a treatment that we've had for approximately 15 years now, and it's been a tremendous advance. Prior to that, the only treatment was to use a laser to essentially burn healthy tissue to keep the blood vessels from growing wild. And so this has been a tremendous advance. The dry form is far more common. 80% of people with macular degeneration have the dry form. And typically, we get early warning signs of this by when we look in the eye, we can see drusen, which are lipid protein deposits that can build up in the central area of the retina. I'll be showing some pictures of some of the advanced forms, one of my patients later on. But essentially, what happens is that the cones and some of the rods in the central areas just start breaking down. Which is over requesting remote control of your screen. Do I approve that?
I don't see what you're saying.
Okay. So hopefully that's not going to prevent me from advancing. But anyway, macular degeneration is something that almost everybody, if you live long enough, will have some reduction in your retinal sensitivity. Some of these studies found that of people in nursing homes, by the time that they're 80 years old, about 25% of the population had some form of macular degeneration. And by the time that they're 90, as much as 75% of the population can have it. That doesn't mean it's inevitable. And these are old statistics. And with the current treatments, I think that that's improved. But there still is a tremendous number. There's about 200,000 people who develop macular degeneration in the US each year. Okay, I'm going to admit Steve Kravitz. Well, I don't have to. Good. Okay. So what do you see if you're starting to develop AMD? First is just blurred vision. And I encourage everybody to periodically cover up one eye at a time, just cover up the left eye and then the right eye, or looking at a page of print in a book. If everything is clear, for the most part, you're probably okay. You still should be seen periodically to check out what the physical eye looks like. But if you do see central shadows, if you see wavy or distorted lines, that's a warning sign. Typically, it's like looking through a water droplet. And if you look at a page of print, instead of being straight, it'll look like it's curved or that it's being distorted. And that's a warning sign. Okay. Let's go on. So in terms of what the major risk factors are, number one is age. That's not something that we can control, of course, but what we can control is smoking. And people who smoke are 3 to 4 times more likely to develop macular degeneration. If you stop, that statistic goes down, but it's still, if you've ever smoked, you still are at greater risk than if you had never smoked. Obesity, being in good shape, taking care of your body helps to protect every parts of your body. That's true of your eyes as well as your cardiovascular and your muscular health. Exposure to sunlight is another risk factor. We do recommend people who are considered at risk to have ultraviolet protected lenses. Most modern lenses, polycarbonate lenses and the like, do provide a screen for ultraviolet light, but it's important that that be done. Of course, 80% of the ultraviolet light that we're exposed to, you get in the first 20 years of your life. So it's probably not optimal, but it's it's still important to try and protect yourself as much as possible. A good hat for our gentlemen who are follicle impaired is also a very important feature. Okay, other risk factors. Family history, it is something that tends to run in families. There are genetic testing that can be done to help predict your risk, although how helpful that is still controversial. Race, people who have a lighter complexion are at much higher risk than people with a dark complexion. It's fairly common in Caucasians. It's fairly rare in blacks. A little bit more common in women than men, unless you take into account smoking. One of the things that was a little bit surprising to me is that hyperopia is more prone to macular degeneration than myopia, and myopia is actually protective. This is actually very interesting. There's about a 13% greater risk of macular degeneration in people who are farsighted. This is, aside from cataract surgery, this is people who've always been farsighted, as compared to myopia. And you can get about a 25% reduction in macular degeneration for people with mild amounts of myopia. Of course, if you're a high myope like myself, then you're at risk for macular damage just from having the myopia, but that's a different story. Now, the other primary problem, actually, before I go on to cataracts, I do want to say that one of the first signs of macular degeneration is inability to adjust to change in light conditions. In our office, we've installed something called a dark optometry, which can help to predict the risk factors for macular degeneration about 3 to 5 years earlier than other methods. That's something that's about 90% specific, and it's about a 10-minute test, and it really is very valuable. If we find that people are not able to recover from a bright light flash after 6.5 minutes, then we can start them on a protective vitamin, which will help to reduce the risk of progression. And so far, I've been very excited and happy about this, because prior to this, we normally need to wait until we actually see signs of vision loss, or we see signs of physical deterioration in the retina. And in this case, we can actually anticipate the development of macular degeneration even before we can see signs of physical changes.
Well, very quick question.
Yes.
Ed, if you can put someone on a protective vitamin.
My picture's not there now. Where's the camera?
I'm sorry, I couldn't hear you.
I was asking if you can put people on a protective vitamin once you see signs of degeneration or inability to recover from a flash. Shouldn't we all be on these vitamins from the start?
That's an excellent question, and the answer is quite probably. We do know that there's some people who are far more at risk than others. The risk of developing macular degeneration is going to be present even if we don't see anything. So being on an arid vitamin or a carotenoid intensive vitamin is something that most people probably can benefit from. However, it is an added expense. It's an added pill, and most of us are probably taking a bunch of pills anyway. So if you don't really need to do it, it's more cost effective, and it also helps to, from a doctor's standpoint, it helps to give us an idea of whether it's progressing or not. I personally am on the vitamins right now because I'm one of those people who is at risk, and apparently my family is prone toward it. And having the knowledge that of how quickly I can recover from the light flash is something that's useful because it helps to tell me if it's progressing very much.
Are you
Now,
going to share with us what those vitamins are?
well, sure. The ones that I use in the office for the most part is it's called MacuHealth. It's in the early stages. I think that's probably more valuable than the full ARIDS. But for people, the ARIDS study was specifically designed for people who have an intermediate level macular degeneration, and they found that there was a 25% reduction between intermediate level and going to the more advanced level. This is a study that was done in 1992 to 2005, and it really turned the field on its head because prior to that, there was nothing. We didn't have any real good way of dealing with macular degeneration short of using a laser. The ARID study basically consisted of using beta carotene, zinc, and vitamin C, 500 milligrams, and it was very impressive. They since had done an ARIDS 2 study where they replaced the beta carotene, which was found to be a risk factor for developing cancer in patients who were smokers, with a more specific similar carotenoid, lutein and zeaxanthine. And one of the things that was a little surprising is that we really didn't see a substantial bump in the reduction between the two formulas. So both of them are adequate, but I can tell you that almost all eye doctors and will recommend the ARIDS 2 over the ARIDS 1 just because we believe it's both a safer and should be a more scientifically grounded formula. The reason I like the MacuHealth is number one, it's a simpler formula. It requires only one pill a day. It tastes better, and it has been shown to work well. Okay, I hope I'm not getting too far afield. Does that answer your question?
Yeah, thank you.
Okay.
And no, you're not far afield. I want to know everything that I can do to prevent illness rather than treat it.
Of course. Okay. Now, the most common cause of vision loss in not only in the elderly, but it can occur at any age, but it's much more common as you get older, is cataract. The reason we don't take cataract as seriously as macular degeneration or glaucoma or diabetic retinopathy is nowadays we can fix it. If you are starting to develop a cataract, it used to be a dreaded condition. You would need to be in a sandbag. They would knock the lens out, and it required a large incision. It would take weeks to recover from it, and you had at least a 6% chance of retinal detachment afterwards. That was a pretty scary event. Over the last 30 years or so, we've been able to do very refined surgery. Dr. Yasgur is an expert in this, and by using a very small incision, we can liquefy the lens, suck it out through a very small opening, insert a new replaced lens that works better than the original, and all of a sudden you can see again. And in most cases, you can have a good refractive result as well. Now, I'm getting a little ahead of myself, but you don't need to have general anesthesia. It's something that is done in a surgery center, in most cases not in a hospital. And the procedure typically will take under 15 minutes. If you have a really dense cataract, if you wait a long time and your cataract is really hard, it takes a bigger incision and it's harder. Nowadays, because of the advances of technology, we recommend cataract surgery at a much earlier age than we did before, and people are actually looking forward to it. Now, the key to the cataract surgery is the implant. This is the replacement for the lens, and it tells us what kind of visual result you would like. Before you go for the surgery, you want to make a determination. Would you like to be able to see well without glasses for close-up and computer work and wear glasses for distance? Would you like to have better vision for distance and use reading glasses? Or do you want to have a specialty astigmatic or bifocal implant, which will allow you to see both? But there are some disadvantages. The bifocal lenses will sometimes cause a little bit more glare. You might not get quite as crisp a distance vision as you would otherwise, but it gives you more variability or more adjustment in your focusing. So these are all important questions that should be determined before the surgery, because afterwards it's a lot more difficult to change things. But I can tell you that people are generally extremely happy after they've had the cataract surgery, because they get immediate gratification. They get to see better, and in many cases, if you've had a very heavy prescription in the past, it allows you to have a freedom of action that you can only get with contact lenses before that. There are multiple types of cataracts. The ones that we're most concerned about are the age-related ones, because once again, if you live long enough, everybody is going to get cataracts. There are people who are born with cataracts, people with metabolic disorders, people who've had infections while their mother is pregnant. You can have a cataract from trauma or electrocution. Boxers and any other kind of trauma are very prone toward earlier cataracts. And secondary. The most common cause of that is if you've been on steroid therapy. There are other medications that can cause it as well. Back when I was working in the VA, it was very, very common to see people on psychotropic medications developing earlier cataracts. But steroids are used very frequently for many, many types of problems. People with rheumatoid arthritis, people with any kind of inflammatory condition. So that's a common cause. Another one, which is very interesting, is people in hyperbaric chambers. I've had a couple of patients who have gone in for hyperbaric chamber oxygenation to promote healing, and in some cases they've developed very rapidly growing cataracts, and that makes sense because it's an oxidative process. You're getting high concentrations of oxygen, and oxidation is one of the things that does contribute to cataracts. But that's something that a lot of people are not aware of. Okay, how do you know if you're developing a cataract? Well, number one thing is that vision gets a little bit hazy. You find that your night vision may start to get reduced. You have less contrast. You may get glare. If you're looking at street lights at night, you might see zigzaggy. You might see lines. You might see just a bunch of halos and haze around the lights. So those are the typical symptoms. And risk factors, well, people will have family histories of earlier cataracts. I had an uncle who developed cataracts at age 50 and one eye only, and a first cousin who also had the same situation of a cataract developing at age 50 and one eye only. And then the second one didn't develop for another almost 20 years. Certain types of diseases can speed it up. Any kind of inflammatory process can increase it. Long-term steroid use, as I've already mentioned, injuries, trauma, general inflammation. If you've had uveitis, if you've had retinal detachment, then it's very, very common to develop a secondary cataract afterwards. The number one risk factor, as with most things, is smoking. I'm sure that everybody has already been counseled to stop smoking, but it still is a major problem. It's addictive. It's something that gives people satisfaction, and it improves concentration in some cases, and it helps to keep people's weight down for certain individuals. So there are people who just have a very hard time breaking the habit, but you should do it anyway. Diabetic retinopathy. Diabetes is epidemic around the world, not just in the US, but it's something that's more common in affluent societies, and we have lots of food around. We constantly are getting food and tasty treats, and so that is something that definitely increases the risk of diabetes. There are thoughts that 50% of the population is going to develop diabetes by the time that you're 50, or at least be glucose impaired. How that affects your vision. If you have diabetic retinopathy, normally with diabetic retinopathy, it starts to cause patches. You get little areas that are blurred out. It's not the same thing as a floater, but it's very, very variable in terms of how it affects you, because when we look inside the eye, and I'll show you a picture later on, you can see little patches of bleeding. You can see exudates of lipids escaping from the cells, and that causes degeneration of some of the retina. And so each of those areas that is damaged, it reduces your vision to some level. Unfortunately, a lot of people walk around with diabetes and don't see their eye doctor, and that's a big mistake. Even if you don't have any signs of vision loss, you really don't know what's going on inside your eye unless you look, or somebody has a chance to tell you. And if it reaches a point where you're starting to see vision loss, in many cases, that's going to require severe treatment that might have been avoided if we can just get a better control over the diabetes. Now, in terms of risk factor, Jews are not a special risk of diabetes more than other groups, other than the fact that we tend to eat very well. It used to be considered a Jewish disease back in the late 1800s. In the German sanatoriums, they were reporting that Jews were constituting 25% of the people who were attending. Whether that was because Jews were just more health conscious or not, I suspect that may have been the case. But right now, Jews are at high risk, but no higher risk than others. The people who are at highest risk are people with darker complexions. For Blacks, Indians, Hispanics, they have by far the highest rate of diabetes. They also have the most difficulty incorporating vitamin D, and that is something that I feel is an important factor. If you are at risk of diabetes, I would encourage you to get a vitamin D evaluation, and or just take at least a limited amount, because it's something that has been shown to be of help. In terms of duration of other risk factors, if you've had diabetes for 20 years, then you're at higher risk than if it's something that's just started. But even if it's just started, even if you don't know that you have diabetes, you can have diabetic retinopathy. And about 7% of the cases, diabetic retinopathy will occur before the person has the diagnosis of diabetes. Lifestyle. If you're a drinker, a Shabbos Kiddush will give you an excuse for. But if you're in the habit of having a drink every day, that is something that has been shown to be damaging to the liver, and something that will increase your risk of diabetes. Pregnancy. Not everybody, but a fair number of people will first show signs of diabetes during pregnancy, and that's a risk factor. If your wife or friend has had elevated sugars during pregnancy, that's a stress test, and it tells us that you are more prone toward developing it. Most of the people at this lecture or at this talk do not have to worry about that aspect. Hypertension is a major factor. Diabetes and hypertension tend to go together. There is a tremendous correlation, and if you have hypertension that is not controlled well, then your risk of developing diabetic retinopathy is significantly increased. And in terms of what we can do about it, the most important thing is just to keep your blood sugar under control. Even if you control it perfectly, it doesn't mean that you're not going to have any risk, but that is by far the best way of minimizing your risks of developing diabetic retinopathy. Glaucoma is the other major issue. It's something that is a little bit more rare than the diabetic retinopathy or cataracts or macular degeneration, but it's the most insidious because you don't know that you have it until it's fairly advanced in most cases, unless you have gone to your eye doctor regularly and you've had your eye pressure checked. There are a couple of different types of glaucoma. The less common in our society is a closed angle. That's more common in Orientals. The open angle is by far the most common. The difference between these two is the angle is the angle that the iris makes with the cornea. There's a drainage system there, and if something is obstructing that the fluid outlet from the eye, then the pressure can build up. If you have a narrow angle and your eye gets dilated, and that can occur because you go to a movie theater and it's dark, or you're taking an anti-anxiety medication or a allergy medication and it causes your pupil to get a little bit larger, that can sometimes cause a rapid increase in eye pressure if the angle gets closed, and your pressure could go from 10 to 50 in a short period of time. If that happens, then your eye gets red, it starts tearing, you get severe pain, and you can lose vision very rapidly in that situation. So that's a true emergency. Open angle is far more common. That has essentially no symptoms unless it gets very severe. If you get pressures in the 50s, then you're going to start feeling a pressure or headache or brow ache. But for most people who have pressures in their 20s or early 30s, they don't even know that they have an issue until they go to the doctor and they say, "My God, you got a problem." And what occurs with glaucoma, in most cases, it's because of loss of your side vision. I'm going to show you a visual field a little bit later, but unless it's fairly advanced, you really don't know that you have it. But the three things that we use in order to measure and follow glaucoma is number one, visual acuity. We measure the eye pressure. We take a look at the inside of the eye and see if the optic nerve looks like it's at high risk. And we check the visual fields, which will check your side vision, and we'll see if there's any blind spots or gaps there. Once again, in terms of symptoms, the symptoms are usually present as it gets more advanced, but in the early stages, you're not going to normally notice it. You can have 20/20 vision and not bother you, but you may sometimes get foggy vision. You might get brow headaches. You may have difficulty adjusting to rooms. You may get rings around lights. That's something that I've had a number of patients report. It's more common once again in blacks, especially Southern blacks. It's more common as you get older. Having a family history is very important. It's certainly much more common if you have a blood relative who's had it. We can measure the thickness of your cornea. That's an additional risk factor. And males are more common than females, but I certainly see a large number of females who have it as well. Now, for all these conditions, one of the questions is, what can you do about it if you're losing your vision? I do a lot of work with the Commission for the Blind in New Jersey, and the number one thing that people complain about is loss of their ability to read. And as long as you have some usable vision, then by using special magnifiers, special reading aids, we're able to allow you to read again in many cases. It sometimes requires eccentric viewing. What that means is that looking straight ahead at something, if you have a blind spot in the middle of your field of vision, that doesn't help. You sometimes need to turn your head. You need to look around the area that you're looking at instead of directly at it. And then we need to be able to blow it up by using either a telescope. I use a handheld spotting telescope often to allow people to be able to see who's coming up the walk or be able to spy on their neighbors. We can use very high-powered reading glasses in order to provide the ability to read for somebody who has a central vision loss. We need to blow up the field of vision 5 times to up to 10 times. You may only be able to see a couple words at a time, but sometimes that can make a huge difference if you're trying to read your mail, if you're trying to write a check, if you're trying to go over your finances. And so there are many things that can be done. The state of the art is a closed circuit TV where you can put a letter or a book on a platform and put it on a computer monitor where you can blow it up 10 to 15 times. That does help quite a bit. We have portable devices in my office which allow you to see price tags on at a store, or be able to read a menu, and that can fit in your pocket. So that's something that's very versatile, and in many cases I've been able to restore vision for somebody who hasn't read in 10 years, and all of a sudden they're able to read the newspaper again, and that is very gratifying. Now, I would like to go over some of the technology that we use in my office, and which is available fairly widely nowadays. One of my favorite tools is the OptoMap. This is something that in my office we're doing on virtually every patient. We want to have a record of what the retina looks like. This is all the different things that can go wrong in the retina. You can have a retinal detachment, which is very serious because it can cause total blindness. But if you catch it early enough, it normally would just cause flashing lights and hazy vision. And if we catch it at the right time, in many cases we can have it repaired by a retinal specialist, a retinal surgeon. We want to look at the optic nerve in diabetic retinopathy. You will sometimes get new blood vessel growth there. I'll show you a picture in a few minutes. You can have a cancer, a melanoma in the retina. It's very common to have floaters, and these are all things that we can see with the photo, and we can share it with our patients so they can see what's going on. And in terms of compliance, if I tell somebody that they have glaucoma, or if I tell somebody that they have diabetic retinopathy, it's just words. But if they can see a picture, then it does improve compliance. Now, this is one of my patients who had severe proliferative diabetic retinopathy. And hopefully you can see this on your screen. What we're seeing here is there is blood vessel growth that becomes very spindly and leaks. So you can see that there is bleeding over here, here, basically all over the retina. There is also some neovascularization at the disc, right where I'm pointing the arrow, but it's sparing the macula. So this person, this is the macula over here. And so this person actually had decent vision, but it was, I think, reduced to about 20/50. but they have some fibrous growth over here. The fibrosis can lead to a retinal detachment, and that can lead to very severe vision loss. So this is something that actively needs treatment. I referred this patient for a retinal treatment. They got an injection of the vascular endothelial growth factor inhibitor, and they did lose some vision, but I believe that it has been able to be maintained. But this person is a high risk for vision loss. Macular degeneration. I see a lot of these patients. This is one of my patients who basically is legally blind. The area over here is called geographic atrophy, and the macula has completely blown up. It's non-functional. So they have a blind spot right in the smack in the middle of their field of view. But the peripheral retina over here is okay. So they are able to walk around, but they definitely need low vision aids. They need to, at this stage, this is a past where the vitamins are going to be helpful. But if you have it in the early stage, then vitamin therapy will help to keep it from getting to this point. And I can tell you that we hate to see people at the end of the road who have just put things off because they were afraid of what they might find. And finally, Lee, I'm going to get to you soon. This is one of my most frightening patients. This was a friend who had never had an eye examination before. She came in at 52 years old for her first eye examination. And I found that she had 20/20 vision without correction, but she said that things were getting a little bit blurry. She was having a hard time driving at nighttime, and she couldn't read. She'd been using reading glasses for the last 10 years and never needed to see an eye doctor. And now she's just getting to the point where her husband forced her to come in. So I examine her. I find that she's a little bit farsighted. She's able to see 20/20, but it's a very sketchy 20/20. She's missing lines on the 20/20 and the 20/25 to 20/30 line, but she's able to see some letters there. But she's missing about half the line. I look inside her eye and I see very large cupping. The optic nerve looks like it's 80% of it is white. I check her pressures, and her pressures are 50 in each eye. Normal pressures are in the mid-teens. So I'm getting nervous. I do a visual field, and I'm finding this. For somebody who is 52 years old, who's a young woman who's active and working, and you see that all she has is a little window of good vision and a lot of area of essentially blind vision and a lot of area of really reduced vision over here. I asked, does she have any blood relatives who've had any glaucoma? She said, no. Does anybody in your family take drops? No. I have a very healthy family. The next day she calls me and she said she talked to her parents, and they said that they didn't want to bother her, but that their pressures are always normal because they take drops. And they've been taking for years, and everything was all fine. So this is a woman who is permanently losing her vision, and we're hoping that we are able to progress it. She's since gone on to need glaucoma surgery because primarily that her family were protective and did not want to scare her by letting him know that there's a history of glaucoma in the family. And this is something that is a cautionary tale. Know your family history. Know who in your family has had health issues, and know what they are. Hiding that from your family does not help them. It hurts them. And so I'd like to go on to one of my favorite topics right now. We have incorporated recently light therapy, which is we use for treatment of styes and chalasia, and for dry eye issues. Dry eye is by far the most common problem, and it does get much worse after as you get older. And the use of a special high intensity LED red light or special wavelengths of light has been found to be beneficial. I can tell you that I had this myself. My staff basically lines up for an opportunity to have this. It's a very, very bright light, but we use it for about 15 minutes at a time. And one of the things that impressed me is when we're trying to treat a stye, the principle is that we want to raise the temperature inside the eyelid by about 10 degrees, which helps to melt some of the sebum inside. And that's something that is very difficult to do with the hot compresses. So what this does is it can increase the pressure or increase the temperature after 2 minutes to over 10 degrees inside the lid. And the more important thing is that even after 15 minutes, there was still a significant elevation in the internal eyelid temperature. This is something that we really have not been able to do in the past, and that's one of the things that helps to make it more effective. The principle here is that the red light energizes the cells of the mitochondria and allows it to produce a substantial increase in ATP production. ATP is basic energy units of the cells, and so this is something that's been used in dermatology for 50 years. It's something that was first determined by an experiment on the space station in NASA. They were trying to experiment with different wavelengths of light for growing plants, and they found that the astronauts who were using the plant exposure with the bright red light were healing better, and the astronauts who were not involved with this were getting wounds, were getting blisters and lesions of their hands. So they thought that gee, this might be a good thing to use for a variety of skin conditions. And we find that we use a blue light for rosacea and for blepharitis. We use the red light for almost everything else, and we found it to be helpful. And it's something that we've been very excited about. So at this point, I'm going to open up the board for questions. I knew that there were some questions out there.
Does the light therapy eliminate floaters?
It does not eliminate floaters. There are only two. Actually, that's a great question. There are traditionally two things that can be done for floaters. They can use a specially designed laser to blast large floaters, and you can surgically go in with a vitrectomy and essentially vacuum it out. I believe that Dr. Yasker has used laser for blowing up some of the floaters, and he might be able to discuss that in more detail. Very recently, there have been some vitamin therapy that has been used to treat floaters. This is something that is I was just detailed on at a meeting last month, and I believe that the product is going to be available next month. So if you would like, I'll be happy to send information on this new therapy, but that's brand new, and I can't really comment on it because I haven't had any direct experience with it.
Thank you.
Okay. Any other questions?
It's Ed Stein, Dr. Melman. I wanted to ask you about having cataracts removed, whether it's typical to do them both at the same time, assuming that they've progressed at different levels, or does it make sense to have one done and then have the other one done when it's progressed?
Once again, a great question. It depends on how well you're seeing out of the good eye. in many cases, the cataracts will develop at an unequal rate. You can have a 20/20 eye, and if you have a very mild correction, it makes a lot of sense just to do the one and to do the other one as it develops. Typically, the most common scenario is that both eyes are in the same ballpark, and we normally are going to have the cataracts done about 2 weeks apart. We want to make sure that the eye is healing well, and that you have at least one good eye before you start taking on the other one. There are some practices, none in this area, that are doing both at the same time, and it's something that is probably going to be more common in the future. But at this point, the current state of the art is that we are, if both cataracts are at the same level, we're going to normally take them out about 2 weeks apart. If there is a big difference in prescription, if you have like myself, if you're a -6 in one eye or in both eyes, and you have the cataract taken out, and you are now have a 0 prescription in that eye, you're a little lopsided, and so it can be very awkward to have that 2 week period between the surgeries or the like. I have had patients. I had one memorable patient who had cataract surgery done in New York on one eye, and he had a -9 in the other eye, and the surgeon just sent him home and said, "We'll see you if and when you're ready for the other eye." So we had to put a contact lens in the good eye until he was ready. Okay. Anything else?
Yeah, I have another question.
Sure.
Cataract surgery, the corrective lens, correct prism.
No, at this point, I'm not aware of any cataract lens that will correct prism. That's you will still need glasses afterwards, and the prism can be put in the glasses on afterwards. You can try and have muscle surgery. Some people who need prism, who have strabismus, will try and get the muscle surgery done at the same general time period. And I've had a couple patients in that situation. Yeah, prism is a very tricky issue, and a lot of times your muscles just don't hold. You can get you can have a surgical correction of the eye turn, and it can sometimes last forever. Other times it might not kick in very much at all. And it's if you need a lot of prism, it's definitely worth consulting a surgeon about the possibility of getting that corrected.
I just wanted to ask a question about statistical probability of converting from the 0 or 1 stage of dry AMD to the advanced stage. Comparisons of those taking the AREDs to vitamins versus not, if you can quote them. The time period over which the average patient who walks in with the 0 or 1 stage of dry AMD till conversion to a more advanced stage, taking the AREDs to vitamins or not, and the overall percentage of reduction of severe stage AMD in the ongoing AREDs 2 studies, where people are getting the proscribed vitamins for 10, 15, 20 years. So it's all about statistics, what stage you have, and how good these nutraceuticals may be working.
That's an extremely important question, and one that we don't have an answer to right now. This is something that there are huge numbers of people who have early stage macular changes, and it's a much smaller percentage who go on to develop advanced and vision affecting macular degeneration. But I can tell you that I do work with the commission and there's an awful lot of people out there who have severe stage macular degeneration. In terms of statistics, as you are very well aware, the original ARID study found that there was a 25% reduction in progression between people in intermediate stage to advanced stage. The statistical challenge with people with early stage, where you might have many hundreds of thousands of people, and you have to be able to anticipate how many are going to progress on to it. I don't have that information. I actually looked for it, and I just don't think it's available now. But I am very excited about hearing what that is, because I can tell you that anecdotally, almost all eye doctors feel that taking some kind of prophylactic vitamin is important and useful. In terms of being able to statistically say that if you take this, you have a 20 or 30% less chance of advancing, we don't have that information yet. So I'm sorry, I can't really answer that question, Lee.
Ed, David Schwartz here. What's the biggest current advances in contact lenses? What's the newest thing out there?
Okay. Well, the things that I'm most excited about are some of the bifocal lenses. We've been, okay, just a brief history of contact lenses. The evolution has gone from originally the hard lenses to soft lenses to one-day lenses, and nowadays 50 to 70% of patients are in everyday replacement lenses, and that's where most of the technology is going. Over the last several years, there have been big improvements in terms of the physical structure of the contact lenses. Dry eye has been one of the major issues, and we have lenses that have special coatings that help to keep the lenses from drying out and help to make them even more comfortable than they've been in the past. And they also have both astigmatic and bifocal contact lenses that are reasonably effective. We still do not have a perfect bifocal contact lens. It's not going to give you perfect distance and reading vision, but the technology has improved. I personally do wear a bifocal contact lens. The one I'm using right now is called the Reveal multifocal, and it allows me to see the computer screen very nicely. It allows me to read my cell phone very well, and I have 20/20 vision at distance. If I'm going to be spending hours on the screen, I still get a little bit more clearer vision with my glasses. Do you have any specific questions about the contacts?
No, I don't. Thank you.
Ed, this is Ed first. You didn't talk about treatment for glaucoma. I mean, you identified glaucoma in my wife, and she went on the drops, and in 4 weeks she went from 28 to 18, and so it's really a very amazing kind of thing.
Mm-hmm.
Now after 6 months, she's still using them, but she's still back to 18. So I guess my question is, how good is the treatment? Yeah.
Well, the drops are tremendously useful, and it's a huge improvement from 40 years ago, when all we had was pilocarpine, which made your pupil very small, and which is now being reintroduced as a vision aid for people enduring presbyopia. But the most common drop that we use right now are prostaglandins still. These are drops that are very effective at reducing the eye pressure, in most cases 20 to 30% with a single drop at nighttime, which is very convenient and easy to use. It doesn't always work. There are some patients who don't respond as well as others, and we need to either add drops or change over to a different type of drop. And that's something that is done on an individual basis. But in answer to your question, yes, the drops are very effective. They help a lot. if anything is needed, if we find that we are still getting progression of the visual field or any vision loss, there are times where it needs to advance to glaucoma surgery, in which case I would refer to the glaucoma specialists. But I'd say 80 to 90% of patients with glaucoma are able to be controlled for the rest of their life with just using drops, and it's much better to be able to use one drop at night than a drop 4 times a day that's going to cause you a headache.
I have a question. What's a good range of acceptable eye pressure?
That's something that needs to be determined between your eye doctor and you. In terms of what a normal range for a normal individual is, typically anything under 22 is considered to be within a statistically normal range, but that's for a normal healthy person. For somebody who has had damage, we sometimes want to get the pressure down into single digits because our goal is to keep it from progressing. Typically, for somebody in early stage glaucoma, a typical target is probably about 17 millimeters of mercury is a good target. But if their nerve doesn't look good, or if they have extensive visual field damage, then we want to get it as low as we can.
It's Ed Stein again, Ed. You mentioned earlier in your talk about AREDS, and I guess AREDS isn't a brand name, it's a type of eye vitamin?
That's correct. AREDS is a study, the age-related treatment study, and it was sponsored by Bausch & Lomb, who provided all the product. And so Bausch & Lomb has a exclusive on something called Preservision, which was the initial study product. Nowadays, almost every major company has a somewhat similar product available. There are different formulas that contain a lot of different ingredients. Typically, the AREDS formula, which is just 6 ingredients, the primary one being zinc, anticarotenoid, and vitamin C, they found that 2/3 of the people who were using that in the study were also using a multivitamin, and so it is recommended that a multivitamin be used with the AREDS. They do have some formulas that incorporate not only the basic products that are found in the AREDS in the Preservision formula, but also have multivitamins with it. It's a personal choice. If you want to take just one product and incorporate everything, then that's something that is possibly preferred. There are always chances of side effects if you're taking kitchen sink vitamin that has 100 different ingredients and different levels of concentration. So I have some patients who are on something called MaxiVision, which is a kitchen sink vitamin that has almost everything in it. Others who take whether the MacuHealth, which is a very simplified formula, but which probably should be taken with a multivitamin as well. So there are different standards of taking it.
For someone who has no particular problem with their eyes, and our average age in the club is probably 75 or something around
I think you're low.
Around that age.
Yeah.
Are you recommending that that type of specific vitamin be taken as a preventative?
Once again, in my office, we're able to identify who is at risk. Since the vitamins are probably an extra $30 a month or so, if you don't need to take it, if we're not finding that you have a special risk factor for it, then that's useful to know. But if you've ever had any family member who's developed macular degeneration, there's no harm in taking it. Actually, the very little risk in taking, I should say. For people who are taking the original formula, It had 80 milligrams of zinc in it. High levels of zinc have been associated with Alzheimer's and certain other issues. That's very rare. They really did not find any body suffering from other issues. Of the 4,000 or 5,000 people who are in the original study, but it's still a potential concern. So generally speaking, most people, if they don't need to take something, prefer not to. But from a personal standpoint, yeah, I think that if you're over 60, it's probably a good idea to be taking one of the macular protecting vitamins. I guess that's a simple answer.
Thank you.
Fantastic. Thanks, Ed. Are any last questions before we let Ed go? Or at least-
Can I get a word in? I know I
Sure,
got in
please.
late.
Bill,
First
you
of
can always
all,
get a
Ed,
word in.
I want to say this. When I had my cataract surgery, remember when I went for the left eye, they called me up immediately to come in. I was still awake when they put the lens in. Is that a chance normally, or it was just one of those things that happened because of the calling?
You're almost always awake during the procedure, but they normally give you an IV to help you relax. Most people do suffer from what is called a surgical amnesia, where they don't really remember very much about the actual procedure. But you're right. If the IV has not had a chance to kick in, you may be more alert than you would like to be. But the cataract surgery is almost always done while you're awake, and you are able to respond if you need to turn your head, or you'll be able to listen to the music. But you may have been more awake than you wanted to be. That's not common.
Yeah. Well, thanks for taking care of me.
My pleasure.
Yeah.
Okay, well, I think that we're probably timed out. I hopefully have not abused my welcome. I appreciate the audience and the opportunity to give this presentation, and hopefully everybody will have eye health forever.
Thank you, Ed.
Yeah, thank you. I certainly appreciate all that information. And I am at the point where I'm looking to do anything I can to save my vision and preserve it. So again, much appreciated.
Thank you.
Phil, is it possible I can have Dave Singer email me his address so I can send him a sympathy card? I don't know if he's hearing me or not.
Everybody heard you.
He doesn't
I
seem
heard
to
you,
be
Bill. I
Yeah,
heard you.
Okay, can you email me your new
Sure.
address?
Sure.
Okay, thanks a lot. I'd appreciate it. That's all I have.
Oh, okay, thanks, Bill. I wanted to quickly touch base. Don, are you still on? I don't see you in the list.
I'm here.
Oh, terrific. Do you want to remind everybody when the picnic is coming up?
The picnic is July 31st. Again, we're going to be at the Red Bank Battlefield. I'll be having or trying to set up a Zoom meeting in a couple of weeks for those people that have volunteered to assist me with that. This year, it'll be a $10 fee per person, and I'll be sending out a flyer to Randy probably next week, since we're about 8 weeks out from the event. So we're hoping for a good turnout. We're hoping for good weather, and it's an outdoor event, and should be a good time.
Yeah, it was beautiful last year. If we got that same weather, I couldn't be happier. And the same turnout, we had great participation.
And if I could ask Ed Melman a question that just came to mind.
Sure.
I find that my eyes start hurting when I watch the Philadelphia Phillies. Is there anything in your arsenal for them?
Yes, get a really high draft pick.
Watch the Yankees.
Yeah, as somebody who watches the Phillies, I'm one of the long suffering, and I wish I could give them some help. I can tell you that the MacuVision, the same product that we use for macular degeneration, has been shown to improve reaction time. So I think that I need to ship over a couple bottles of devices and make sure that their bat speed is improved. So far it's worked pretty well for a couple of their hitters, but not much. There are too many people in the 100s.
Well, please send it same day delivery.
Don, the problem is not just that they're bad, they also take a long time to be bad.
Yeah.
And really sit there in 3.5 hours and still not win. It's really painful.
Painful.
So people are proposing to get a 2-hour limit. Whoever is ahead wins at 2 hours, because really it's impossible, the length of the games right now. Yeah.
Well, they're actually going to put the pitchers on a timer so that they have to make a pitch every 20 seconds, I think it is.
Yeah, but then you have 300 fouls. It just seems like it just goes on forever, and almost no hits. Strikeouts and home runs. That's the only thing you see. No, it's really the game has turned very, because of the computers, they've moved the fielder, so it guarantees infield outs. So
we've got 10 minutes before the art starting off with the investment club meeting. Very good. If somebody else who was at the law enforcement breakfast would like to give a 1-minute recap, I would love it.
I will do it. Yeah.
Great. Thanks, Rich.
Yeah. I think of all the police breakfasts we've done, I think this was one of the most successful. The speeches were great. The presenters were great. We had a wonderful turnout. We had much wonderful help from the temple. As usual, they went above and beyond what we would expect. We had so much help, especially in the kitchen, which I appreciated. So all in all, it was great. And I thank all the guys for coming out. I appreciate it.
Thanks, Rich. And nice haircut. Okay, does anybody else have any business, any other men's club business that they'd like to share before we wrap up? Any good in welfare? Wow. Just speak up, don't raise your hand. I can't see everybody on.
Have we researched a new location, or where are we on that? Did I miss that? Or
with locations, I spoke with Oded yesterday for a bit. He's going to be working. He is very anxious to work with us to come to some agreeable solution. He's going to look into it more on Tuesday when he's back, and we'll let you know as we learn more. We will keep you informed as to where we will be meeting in person. But until we do, everybody stay very safe. There is a lot of COVID floating around, even if you're vaccinated. So, please just be wary, especially indoors.
Bill, I have good and welfare. One quick
Terrific.
thing.
Please, David.
I moved back into my house in Mount Laurel. I'm now back in New Jersey. And anybody that can help with boxes or anything else, please get in touch with me, because I have a lot of work to do to fully move in here. Thank you.
You're looking for help unboxing?
I can always use help moving stuff around.
Very good. Do you want to put your email in the chat?
Sure.
And anybody available can get in touch with you?
Anytime.
Terrific. Everybody have a wonderful day, Happy Memorial Day, and enjoy the rest of the weekend, the long weekend. I will talk to you all soon. Take care.